Welcome to Vision 2020 USA's Spotlight Series. Today's topic, NORC, U.S. Vision and Eye Health Surveillance System. Featuring Dr. David Rein, Senior Fellow and Program Area Director of the Public Health Analytics Program, and John Wittenborn, Senior Data Scientist, both from NORC at the University of Chicago. The Spotlight Series is hosted by Dr. Rajiv Ramchandran of the Flom Eye Institute at the University of Rochester and Dr. Dean Van Asdale of the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
Well, welcome again to Vision 2020 Spotlight for March 13th. We're very honored to have John Wittenborn and David Rein talking to us from NORC about the Vision Eye Health Surveillance System and the Vision Health economic model that they have. So John, as I was saying, is the project director for the National Vision and Eye Health Surveillance System. Has been supported by the CDC and was named 2020 the most outstanding project by of the year by the American Public Health Association. It is probably the most widely available public health resource for vision in the United States, where users can freely and easily access many of the best resources of vision and eye health data. And it summarizes more than probably 200 vision and eye health outcomes. It's probably old data, probably does more now, and has many data sources and over 300 or 250 million at least patient level records per year. And I'm sure that's growing and expanding from this information that I have. So that's John, and we have David as well. So David is been director of the NORC's Public Health Analytics Program, and he specializes in developing surveillance assets based on secondary data sources, health economics, and comparative effectiveness evaluations. He's an internationally recognized expert in visual disorders and use of secondary EHR, or health records, and administrative claims data to improve surveillance, cost effectiveness, and economic metric estimates. So with this, I turn it over to John and David to talk to us about the Vision Health surveillance system and their economic evaluation model. First, I do want to put a plug in for our meeting at ARVO. I don't know how many of you are going to the Association for Research Vision Ophthalmology conference. We do have a Vision 2020 USA meeting on that Sunday in person from 6:30 to 8 o'clock at the Hilton Garden Inn, right across from the Denver or Colorado Convention Center in Denver. And we hope to see whoever is at ARVO there at that time. And there's other meetings going on at the same time. So if you can pop in and say hello, that would be great. And then on Monday, we are been awarded a special session. So Dean and I have applied and obtained a special session at ARVO to talk about diabetes and data and the implementation of data into really making sure that we're creating eye health and improving eye care and access to eye care for those with diabetes. So that session is going to be teed off by Dr. Michael Chang, the NEI director. He's going to come and give the first presentation. So that's at 1:15 to 2:45 Mountain Time, of course, in Denver. And it's not going to be televised or broadcast or anything. So it's basically, if you're at ARVO, please do come. Our session on Sunday, though, will have a Zoom component for people to listen in. Won't have really interactive Zoom, so where you can't at least talk. You may be able to chat back and forth, but you can't really talk on it because we just don't have the AV capability. But hopefully that will give some credence and access to folks to learn more about what we're doing. So those are the two dates, Sunday and Monday. And with that, I turn it over to John and David.
Great. Thanks, Rajiv. I think I'll get us started, and then David, feel free to jump in, and we're going to take turns doing this. I'm first going to try to share my screen here. First, thanks Rajiv and everyone in the committee for inviting us back for doing another spotlight. We did our last spotlight back in September 2024, I believe, and we've put together a presentation of sort of everything that's new since that last spotlight. Then I saw the meeting invitation mentioned economic burden. So like, oh, so we added a little bit of that in there, but that's kind of a little bit older, but we'll go over some of the resources. So basically what we're going to do today is do a quick background of VEST for people who aren't familiar with it and how you can access the data. And I'm going to be pulling up sort of live websites as we go and just doing a really quick demo of each. And then we're going to talk about 3 new or upcoming data products, which we're really excited about. The zip code map, community vision profiles, and updates to the visual acuity loss modeled estimates. So first, a quick background on VEST. Rajiv, you mentioned, yeah, it started back in 2015, which was a long time ago. So it's been a decade in the making. And we are, I think at the end of this month, probably coming to the end of our cooperative agreement with CDC. So we will be rolling off, but CDC is basically bringing it in-house, and they're going to hopefully continue to maintain it and update it and improve it. So, I don't think it's going anywhere anytime soon, but it might be changing. But along the ride, we've had a great time working with the vision community, with CDC, and our expert panel, all our partners who provided their expertise, their assistance, their data, to build the system, which has become a pretty robust surveillance system. So we're up to 14 different data sets on the VEST website, where we summarize and synthesize prevalence information. And these include examination studies. So this would be, national examination studies or published examination studies, national telephone or interview surveys, claims and encounters database. So that's Medicare, Medicaid, private medical insurance, vision insurance, and military health system. And finally, we also have summary data from the IRIS registry. So all that is available on the VEST website. We take all this data and we've defined over 400 different indicators now of vision eye health outcomes, including visual function, eye health conditions, and eye care services. So lots of data, lots of indicators for people to explore and take a look at. And sometimes that seems a little bit overwhelming. So the capstone product of VEST are what we call the modeled prevalence estimates. So these are where we take all the data, all the best data that is available. We learn everything we can about the data, about the indicators, and we use statistical integration modeling techniques to produce sort of comprehensive single sets of estimates. And we have these for visual acuity loss, AMD, diabetic retinopathy, and glaucoma. So if you want sort of one number of how many people in your country, your state, your county, by detailed demographic group and by disease stage, have these conditions, the first place we would suggest you take a look at is the best modeled estimates. So how do you access all of this information? Well, you go to the cdc.gov vision health data. That's the best website. And on it, you'll find the best application that includes data visualizations, lets you explore indicators. You can see charts, tables, trend lines, maps at the national, state, county level. And there's lots of things you can do. You can change the data source. You can apply different filters. You can make comparison charts. So there's a lot of sort of analysis functionality right on the website. So you don't have to download the data to do sort of simple queries and analyses. I'll pull up the VEST website. So hopefully most of you guys have seen the VEST website. The homepage was sort of redesigned about a year ago. But if you come to the homepage to get to the online interactive explorer, the data explorer, you'd click here. The data portal, you would click here. There's a lot of static content on this page. So if you want to know, like, what are we measuring? We have all the different case definitions. So each of these pages has a lot of information. So like, what survey question is this? How do we define procedure codes? So all the detail you would need about how we're measuring things is available here. You can also click on data sources. And if you want to know all about the American Community Survey, and how we analyze the American Community Survey, we've got a lot of information here. So we've got the questions, we've got sort of how we did the analysis, and then there's links to data reports where we have very detailed information. Then there's the data portal. So data portal is actually much more heavily used than the application, but a lot of people that use the application are not aware of the data portal. So the data portal allows you to access the public use files of all the data that is in the backend of VES. So anything on the application, you can just get to the data set and you can download data sets. So I mentioned the VES modeled estimates are capstones, like you can download this data set. Here's the market scan commercial insurance, National Health Interview Survey. So you can download or you can run queries right here on the data portal. So it's a very powerful resource. And the reason a lot of people use this is because this is accessible from data.gov. So a lot of people outside the vision community will find these data sets and sort of start learning a bit about vision and eye health, basically from outside the field going through this route. But we're hoping they can start making their way over to the application as well for that experience. And then, yeah, as the invite said, we were going to talk a bit about the economic burden. So I think we published this in 2021 called the Vision Loss Economic Explorer. So this is available on the CDC website. It contains national and state level economic burden estimates based on the year 2017. So what we're estimating is the economic burden of self-reported vision difficulties. So we are not estimating cost by disease. So this is strictly economic burden of vision difficulties. But we do have these estimates at the total per state and per person by state, stratified by medical expenses, nursing home expenses, other supportive services, and productivity losses. And there's also the publication here. So I'm going to pull up the Vision Economic Explorer. So this is live on the CDC website right now. There used to be a lot more to it. Unfortunately, the CDC, through the last few iterations, the website has had to pare things down. So it's down to only one page, but it does have these maps. So these will allow you to use these drop downs, and you can select different combinations. I think we're getting some background noise.
Let's see who's not muted here. Okay, thank you.
So there's, you can basically just do all these different drop-down interaction terms, and you'll get burden estimates. We no longer have sort of the resource for you to see the really detailed charts and tables, but what you can do is basically download the CSV data. So I'd suggest if you're interested in economic burden, you should probably look at the paper. His first author was David Rein. We were talking about the methods and exactly what we're doing, and then you can download the CSV. And the CSV looks like this. So basically for all combinations of state, age group, sex, and cost category, we have total cost and per person cost. So if you need an economic burden estimate of vision problems in your state, you can pull all the information you need basically from the CSV. And then all of this is, you can cite the paper by David. Get back to the slides. All right, well, that's what's already been up on VES. So all that is available, has been available, but what's new are 3 new data products that we're pretty excited about. And that includes a zip code level map, a new resource called the Community Vision Profiles, and updated estimates to our visual acuity loss modeled estimates. So I'm going to turn it over to David to talk about the zip code tabulation area.
Thanks, John. You're gonna have to run the slides for me because
Yep.
So thanks for the introduction, Rajiv. I will mention John does most of the work on VES and is certainly the project director. I do also have the privilege of being the PI on it, so just wanted to add that. I know we were supposed to talk about the Economic Explorer, but it's so old and so impoverished at this point by the CDC edits that we wanted to talk about some new resources that we have available to the community that I think could be really useful. The first one, our goal is to provide reliable estimates of the presence of vision difficulty at sub-county geography. So kind of the motivation for this is um, at the county level, counties are really good, particularly in rural areas, for measuring vision prevalence as a unit of geography, although they have some problems. You really start to run into problems in large urban counties. So particularly like think of a place like Los Angeles, which has more people in Los Angeles County than 40 other states in the United States. The problem is twofold. The first is that you don't get granular estimates of where to target resources within urban areas. And also, there's an inequity in that because urban areas tend to be, on average, more wealthy than other types of areas, on average, their measured rates of vision difficulties are lower. So it leads to an incorrect belief that there's not vision problems in those places. Um, the other question that was really kind of getting at us is that we would really like to know like which places in the country are uh, persistently over time high prevalence in terms of vision difficulties. But the ACS estimates from which, we would get this information are really squirrely. So the margins of error are so large that they bounce around. And it's difficult to say, like, yes, that area is really high and it's probably really high with vision difficulties, but we don't really know. Um, and then the other problem is that a lot of sub-county levels of geography, like for example, a census tract, um, are not intuitively usable by most public health practitioners. So nobody really knows what census tract 006157 da, 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 da is. It doesn't have a name. It's not really associated with a neighborhood indicator. But zip codes are things that everybody knows, right? So especially in your city, you kind of have a sense of where the zip codes are. You can pull up a zip code map. Um, uh, so we wanted to try to create some more reliable estimates of vision difficulty prevalence at the zip code level. Okay, next slide. Um, So to do this, the Census Bureau releases estimates of vision difficulties based on the American Community Survey question, are you blind or do you have serious difficulty seeing even when wearing glasses? It's really the only survey where you can get this level of detailed geography given its very large sample size. And even then, with that very large sample size, you have to compile 5 years of data at one time across the track in order to get a reasonable estimate. Some ZICTAs aren't sampled in each year. It's really important to use the 5-year file. So they have these estimates, but they're not exactly easily accessible if you're not skilled using the Census API. There's no existing map of the ZICTA estimates, and many of the estimates are quite unstable and have very wide margins of error. Next slide. So we engaged in a study to create reliable ZICTA level estimates of visual difficulty. Um, and the way that we did this was first we measured reliability at the ZICTA level by transforming their margins of error into a smooth sampling variance. And then we used a Bayesian multi-level model to estimate a statistic called the inter-unit reliability, which basically measures, how well this estimate correlates with itself. Uh, and we classified areas as having either good inter-unit reliability or IUR if it had a IUR stat above 0.75, moderate if the IUR was between 0.5 and 0.75, and poor if it was below 0.5. And then what we did was we ran an iterative process to look at all of the zip codes, check their reliability. And if they had poor reliability, we would then merge them with their next neighbor that also had poor reliability, recalculate their IUR stat, and then check again, and then see if they still had poor reliability, we would merge them with the next ZICTA in order to translate these individual ZICTAs into a set of ZICTAs with good reliability, and then ZICTA clusters or sets of ZICTAs together, where when you pull the data across the different ZICTAs, you can get at least moderate reliability. Next slide. And then these estimates are not very useful unless you can give people a way to see them and interact with them. So, following like our principles of trying to provide visualizations, we created an interactive ZICTA level map. This is hosted externally from the main VES page and application, and sits at this URL right here. So you can open this up right now, but we're going to show you in just one second. But if you wanted to open it up and bookmark it so you can look at it later, that's the URL. The map allows you to visualize the ZICTA level estimates, and then also highlight ZICTAs with significantly higher prevalence. So really to get at the question, where are the specific micro areas that have high prevalence defined as one standard deviation above the mean, or very high prevalence defined as two standard deviations above the mean. And you could see how this would be useful, so for example, if I was trying to do vision services here in Atlanta, the first thing I might want to look at would be the areas of the city that had the highest prevalence. Next slide. This is what it looks like, and then John's gonna switch to the actual interactives. So here's the ZICTA level map of the United States, with darker blue showing the areas with higher prevalence. You can zoom in on the map, I think, to see more detailed areas. I only really know Atlanta, so we better go to Atlanta. So you'll see like an example. So Atlanta, Fulton County, if you measure Fulton County as a county, it has relatively low prevalence of vision difficulties compared to the surrounding counties in Georgia, but actually has several ZICTAs within Atlanta with quite high prevalence of vision problems. So uh, um, John's highlighting 30310, which is actually pretty close to where I'm sitting right now. What's the one next to it? 30311. So these are all areas that are probably not recognizable to people not from the Atlanta area, but if you're from around town, you kind of know that this is southeast of the city. If you zoom back out, you can, let's first show like the map features. You can also just go straight to like Alaska, as opposed to trying to squeeze it all in one map, or Hawaii.
Nobody's doing this.
Our server is really slow today. Let's go back to the contiguous US. Or to really get to, sort of what I think this group might find the most interesting information, you can just filter by the high prevalence sectors, which you can see here or the very high prevalence SICTAs? And I saw Mitch was on the call. Maybe some others of you are familiar with the CDC grant that was issued to, oh, and Dean is on the call also, to basically do vision screening and research in the highest prevalence ZICTAs, and we created an early version of this list of high prevalence ZICTAs. So this is now the refined and cleaned up version of this in map form. All right, want to move on to the next one? Okay, the other thing that we created are what are called community vision profiles, which do rely on the census tract information. So the goal for this project was to provide actionable data to people working in communities about people with vision difficulties and uh, the characteristics of the people with vision difficulties and then the characteristics of the community that they are living in. Um, uh, so the same problem, like in a lot of areas, the county level estimate doesn't do you a lot of good. You really need more information on the prevalence of vision difficulties in specific areas. Um, you might want to know, what characteristics do those people with vision difficulties have? So are these more or less are these people older? Are they people with uh, uh, independent living difficulties? What are the priority things that I could help people with in that area? And then you might want to know what community characteristics in that specific census tract might affect people with vision difficulties' ability to operate independently. Next slide. Um, so to do this, what we map is census tract level prevalence of vision difficulties based on the same ACS question. Are you blind or do you have serious difficulty seeing even when wearing glasses? We have not done the same exercise of merging the estimates for reliability. Census tracts in general are more reliable than ZICTA estimates because they're designed by the census to provide statistically valid estimates most of the time, but not always. Um, so by using the census tracts, we preserve the evidence of local disparities in vision difficulty. However, some of the point estimates and point values will exhibit wide margins of error in many areas. So you need to use kind of uh, like your sanity check as well as the data to direct the services that you're using to intervene in a certain area. So the implication of this would be use the ZICTA map to really focus in for local area prevalence estimate point values, but then use the CVP track level estimates to give you more information about the specifics about people with vision problems within that census tract. Okay, next slide. Maybe we should do this from the map. Or no,
Yeah.
do we have more methods slides coming?
Yeah, this is the first of three. We
Okay.
can we can look at them one at a time.
Um,
So this is just looking at prevalence. I'm gonna refresh. Something's weird with my browser here.
so this is kind of a fun map because it is scrollable. So you start at the state level. Um, and as you scroll in, it then gives you county information. And then as you scroll into the county, if the server is working, it gives you the individual census tracts in within that county. So again, like here's an example of how the census tracts are not easily recognizable. So this is census tract 211.01 in Harris County, Texas. Like I don't necessarily know where that is, but if you were from Houston, you would know what that neighborhood is. And this top level map just shows you the prevalence of are you blind or do you have serious difficulty even when wearing glasses? Did I raise my hand somehow?
Okay, yeah.
I don't know how I did that. Um, but if you click on one of these census tracts, we have a dashboard that gives you more information. So you can see the prevalence estimate for that county. You can compare it to the county overall as a whole, and then you can compare it to the overall Texas value. Um,
Some of this is a little garbled, so
Still in development, still like
yeah. So this is a work in progress. Yeah. So why don't we go back to the slides now, actually?
yeah.
All right.
Um, okay, so the problem with figuring it so now you know like how many people with vision problems live in each census tract, but you don't really know anything about them. Um, and the data issue is the census only releases univariate estimates for small geographic areas. So you can know how many people answered yes to the ACS blind question. You can know how many people answered yes to the, I'm living in poverty. You can know how many people answered yes to the independent living difficulty question, but you can't from the census data alone, estimate combinations of those factors. Uh, so what we did was we used a calibration method to create mutually exclusive categories of the types of people with vision problems at the track level by calibrating the summary estimates of ACS variables released at the track against the person level ACS variables released in the public use microdata at the public use microdata level or PUMA level, which is another census geography. And really the only important thing that you need to know about PUMAs is that the PUMAs are a perfect sum of all the data that are in the individual tracks within the PUMAs, which makes this calibration method work. The way we did this is we went through a four-step process. So first of all, we identified pillars of concepts of interest with the VEST expert panel. So basically, like, what are the types of things that you'd want to measure about people with vision problems? Well, we'd want to measure um, uh, their economic problems. We would want to measure their disability problems, their other disability problems. We would want to measure if they had housing difficulties, things like that. Um, and then we used correlations to kind of reduce the number of variables that we had included in there. Uh, and then we used clustering to basically create typologies of the type of people that live, the types of people, the combinations of variables that uniquely identify different types of people with vision problems. And we use a classification algorithm to rank the relative importance of each of the variables for those clusters. And then we used a human evaluation and selection process guided by data to look at the different categories that were created and select the ones that both describe the largest number of people with vision problems and then also might offer the best opportunities for programmatic input if you knew this information. So in terms of what we came up with, we estimate, like for Harris County, from the census, that there are 128 people experiencing vision difficulties in that area. In Texas, there's 115,000, or in Harris County overall, there's 115,000. In Texas, there's about 760,000. Looking just at the census tract, we estimate using the combination of variables that about 3.4% of the people with vision difficulties are living in group quarters. 5.4% are children. A little under 25% are people living alone. 17.7% have an independent living difficulty, and then about another 50% are in none of these above categories, and have a mix of other characteristics around them. And the reason we selected these categories as being important is we thought there could be specific outreach and intervention strategies, for example, for reaching people with vision difficulties in group quarters, for children, strategies for people who are living alone, like, for example, meal delivery, or helping them with their daily errands or things like that, or getting out of the house. Or for people with an independent living difficulty, sort of identifying who they are and providing services to help them operate more effectively. Next slide. The next thing that we wanted to include in this map, and I saw there's already a comment in the chat about including community level information, which we would love to do, is that people with vision difficulties may be more vulnerable to community characteristics and challenges. So we incorporate some community level characteristics in the profile, in the census tract profile and the county profile, in order to allow you to visualize the relationship between prevalence of vision difficulty and community level characteristics using a bivariate map. So these aren't characteristics of the people with vision difficulties. It's just a area level characteristic among all people living in that geography. Next slide. And the 4 that we're offering right now is the rural urban continuum code. Within Houston, pretty much everyone is going to be a 1 on that code, but in other counties that you may have a variety of this. We also offer the transit stops per square mile, because obviously people with vision problems might have difficulty driving. So if there's fewer transit stops, a transportation intervention might be warranted. We offer the walk score, which gives a measure of how easy it is for a person to get around in that community, and do things like do their grocery shopping, or get their dry cleaning taken care of without having to use a car. And then we also provide one general measure of the percent of people in the tract below 100% of federal poverty, to just give you a sense of the resource neediness of the area.
And note that these are not real numbers here for poverty, so still work in progress, but these should be the correct numbers.
Getting the data in the correct shape is always a challenge. Do we have a next slide, or is that it?
Let's talk about this. Pull this up. Yeah,
let's show this on the map.
All right. So why don't we select transit stops? So basically up here is where you add the community attribute. And you click apply to map. And what it's going to do is it's going to create something called a bivariate map. And basically there's the prevalence of vision problems is on a sort of blue colors axis, and transit stops is on, I think, an orange color spectrum. And then down here in the middle is the combination. So if you have an area with high prevalence of vision difficulties, but low transit stops per capita or per square mile, it'll be just blue. If you have an area with low vision difficulties and a lot of transit, it'll be orange. If there's a lot of vision difficulties and high transit, it's green. And if there's low vision difficulties and low transit, it's kind of gray. So I picked this one because I thought this was pretty interesting because basically you can see where transit stops in Houston when it hits the suburbs. All the sort of orange-green colors disappear, leaving just the scale of blue. But within Houston, you can see sort of the more, kind of like wealthy areas where you have lower prevalence of vision difficulties here on the west side. And then the east side, there's transit, but also people with serious vision difficulties. So the darker blue areas are where there's high prevalence of vision difficulties, but no transit. So the idea is that you can sort of look at both the prevalence of vision problems and the community attribute and the relationship between them at the same time.
Right. And then like a natural service delivery option for those folks might be to offer them, transit service or ride share service or something like that, if you can identify them and serve their needs.
And as I started to show you, if you click on any tract, county, or state, go below this little profile. So the top row will be the prevalence of vision difficulties. We're going to have the margin of error here. Then we count people with vision difficulties, which, like we mentioned several times, we're still working on this actively, but it's just formatted incorrectly. So this is 67 people. And then below it, we've got something out of order, but basically these percentages all sum to 100%. So these are the mutually exclusive categories we talked about. So these are the calibrated types of people with difficulties. So these are children with vision difficulties. These are people living alone with vision difficulties. And then down at the bottom, we have the community characteristics that are measured among everyone in the census tract, like the poverty level, or the census tract itself, which would be sort of the RUC score, transit stops, or walk score. All right.
This is not quite live yet. You can see we're still formatting and cleaning data, but it will be live soon, and it'll be do they access it from that same site that they access the Zicta map?
Well, we haven't decided URL, but it'll be on the NORC site, kind of like it's visionmap.norc.org. This will probably be like communityvision.norc.org. If anyone has any great ideas, let us know.
Children are just 0 to 17. Though I'm just answering a question in the chat.
Yeah. Okay. So we have one more thing to show you guys. Back to our slides. The updated visual acuity loss modeled estimates. This is again coming soon. So we're going to show you what we're working on, and we're going to show you kind of slightly wonky estimates on a website that we're actively working on. But the best modeled estimates, as I mentioned at the beginning of the meeting, best has tons of data, tons of indicators, but sometimes people just want a number. So that's what the best modeled estimates are designed to get you. So whether it's at the state, county, national level, we take all the best data, we talk to our expert panel, we put it together with statistical models. So we think this is the best estimate that you can possibly get based on the available data. For visual acuity loss, the data is the National Health and Nutrition Examination Survey, which was nationally representative, but it's getting kind of old. And then actually is sort of the anchor point for national prevalence estimates. And then we brought in published population-based estimates from population-based studies. And some of these are newer, some of these are actually older than NHANES, but they do provide more robust evidence on age, race, sex disparities that we can use to kind of get a little nuance to that and reduce our confidence intervals. And then we brought in national self-report surveys. So in the past, people were concerned that maybe self-report is not really useful and it doesn't have anything to do with actual visual acuity or measured vision, but we realized that they are actually highly correlated. They don't measure exactly the same thing, but variation in one actually usually indicates variation in the other measure. So based on that evidence, we're able to sort of fold in information from these surveys on disparities. So we don't use these as prevalence point estimates, but we're using these to get geographic variation. And we use this to get trends at the youngest and oldest ages, which aren't well covered or covered at all in the examination survey and examination data. So basically all these different data sets together go into one big statistical model to produce these estimates. The estimates were released in 2021 based on the 2017 US population, and we are just about to release a big update of these, so we're pretty excited. So as I mentioned, we've been working on VEST for 10 years, and I think this is the culmination of everything we've put together to create these estimates. So before the estimates were just best corrected visual acuity, but we are adding uncorrected refractive error, which has, I think, very important public health implications. And the combination of best corrected and uncorrected refractive error represents the total envelope of presenting visual acuity loss. So this gives you the total envelope of people with that are presenting with vision problems, and it's a big number. So I think this is pretty interesting from definitely a public health perspective, and we're hoping this can help sort of target uncorrected refractive error treatment, because that's one of the real low-hanging fruits in vision health. Another thing we've learned along the way is the importance of socioeconomic status in vision outcomes. So we have included poverty status and educational attainment as new stratifications. Before it was only demographic characteristics, so we now have these. And we also learned that people living in group quarters are at higher risk, or maybe they're living in group quarters because they have vision problems. So we now have stratifications for people living in nursing homes and also correctional institutions. And then finally, we updated everything to the 2024 US population. So that's the most current population we can get. So it's representative of the US population, the national, state, and county level in 2024. And here's a map of it. And I'm going to attempt to log into the CDC here, and we'll show the work in progress. Okay, this is the Best QA app. And again, work in progress. There's some wonky stuff going on the website, but most of it is in here. So the best way to find this is to come to the best application and filter for best modeled estimates. And then, these are the 4 different sort of best modeled estimate products we have. So we're going to focus on vision problems and blindness and just click the buttons. And we have best corrected, presenting, uncorrected refractive error. Everything's basically duplicated in here. This just makes it easier for some people to find. But we'll start with these. So we'll take a look at the best corrected. So any visual acuity loss, 2032 or worse. So what are we looking at? We're looking at it by age group, stratified by poverty. I was playing with this earlier. That's why I didn't pull up a blank map, but you can also do like sex by education. You could filter to an age group. You could filter to race, ethnicity. You can look at adjusted instead of crude. So let's clear this out. Of course, we've got our state maps, got our county maps. Let's take a little bit of time to load up. So here's a county level map. Let's take a look at uncorrected refractive error, because as far as I know, there's never been a map of uncorrected refractive error. So here we go. This is, I think, You guys are among the first people to ever see a map of uncorrected refractive error. The numbers are, these are sort of the preliminary numbers, so they're slightly off, but this is pretty much what the map will look like. And it's kind of similar to what we saw with the Zicta level map. Definitely got some hot spots, kind of Appalachian, New Mexico, deep south areas over here.
Hey John, I think it's would be interesting to also show the blindness map to show how different they are.
All right.
So I had a question while this is loading up. Just wondered, is there a way to link maps that are created for other health issues like diabetes in general or smoking, things like that with these maps?
So you couldn't use the ACS data as your county level indicator for that. As far as I know, there are not uh empirically measured county level estimates of diabetes or smoking. So that's the big limitation. So BRFSS does estimate county level smoking status and diabetes status through the places study, but those are modeled estimates based off internal uh restricted data file. But that would be, I'd direct you there to look at their estimates because those are probably the best estimates. You could use the same method that we're using. So their method in BRFSS is they're mapping the self-report only, so BRFSS places, whereas we benchmark ours to the NHANES data. We have done this as part of another project for hearing loss, which is also in the ACS, and you could do it for any of the 6 question set disabilities, so independent living difficulties and cognitive, assuming that you could also measure those in the NHANES data. You could do this with another outcome measure. So for example, like for AMD and glaucoma, we use NHANES, and then we benchmark to Medicare claims data and Medicaid claims data. So you could try that approach. The results are a little confounded by health services access and different cultural practices in diagnosing and things like that.
And do you have any access to insurance-based diabetes, eye exam, or other health metrics for diabetes, like foot exams and so on, just to see what the kind of the rates are across the country?
Yeah, John can show you.
Yeah, if you come to, here's real live vests, went to the application. So yeah, if you hit diabetic retinopathy, we have prevalence. So here's our modeled estimates. So if you want our best estimate of the prevalence of DR, national, state, or county level, we click on here. But yeah, if you want more nuanced information like diagnosis by stage, diagnosis of any stage, diagnosis of vision threatening, so this would be you know, proliferative or
Macular edema.
macular edema, and also severe non-proliferative is here for some reason. And then we also have self-report. So this is from NHIS, which the NHIS is about to be updated in like a week or two. Also in a week or two, we're going to have self-reported blindness among people with DR. So that's from NHIS. So that's going to be up there in a week or two. For now, we have prevalence by service type. So, I mean, you can take a look at anti-VEGF injections. So this is by state. This
This comes
Medicare
from
fee.
claims data,
This is
basically.
Medicare fee for service and Medicare Advantage combined. So this is very few people have looked at Medicare Advantage data. So we've got it all combined starting 2021, 2022. So we have 2 years of this. So this is everybody in Medicare. This is basically what 99% of the people 65 and older. But you can also look at IRS registry, Medicaid, commercial medical, or you can look at the fee for service, which is basically more or less half the people in Medicare, but we have a lot of years of it. So with that, you can click a trend line. So I always think that's what's pretty interesting. You can see any event if it's
Increasing.
going up. Yeah. And yeah, you can pull this at the state and county level. So that's all the DR stuff you can find.
And John Burroughs on the call was asking about any information on eye care providers or where they're located and things when you do the maps as far as like access to care kind of issues.
We do not have that. We had considered doing that over time and just never, it was never kind of prioritized to invest. It's something that could definitely be done in the future. We're working on a small project to do just that in South Carolina.
Hmm.
So we'll have something like the community vision profile, but with providers and low vision services mapped out. So we're excited about that. But yeah, that wasn't integrated into VESS, but it could be. I mean, there's definitely some challenges. Like you have to use the National Provider Index, and sometimes it's out of date, and there's some issues. But um, yeah, it's not available on VESS.
And a final question for me is, so these are people who've already had eye issues, like they either have like blindness or vision loss or retinopathy or glaucoma. But how about those folks who are at risk for vision loss, like those people who have diabetes and are getting eye exams? So, is there any possibility in the future to look at those kind of metrics about because that's the only tracked metric actually, eye exams in folks with diabetes that has related to eye care. So I didn't know if these type of things from insurance companies would be something that could be tracked as far as what people are actually doing to preserve their vision.
Yeah. All right. So I'm going to show something that recently broke on VESS. So I'm not sure if it's going to work. But if you come up to this characteristics drop down, you hit diabetes. What it should do is filter indicators that are only available among people with diabetes, which is essentially almost all of them. So let's see if this works. So we're going to basically proportion of people who had claimed for an eye exam. Yes, so 57.7% of people in Medicare had an eye exam in 2022 covered by Medicare. So if they had an eye exam covered elsewhere, we don't have it in this data. You can check um, the vision service plan claims, commercial medical insurance, and you might be able to sum them up, and not exactly, but yeah, this is a pretty good indicator of what proportion of people in Medicare are getting with diabetes are getting this. So yeah, I mean, we have maybe like I think it's 30 some 40 something odd eye care services. Um, and so that even includes, wearing eye protection, getting glasses, um, all of these different tests. So there's low vision aids, screening services. So there's a lot. We also have, you can also look at the proportion of people with diabetes that have cataract diagnoses. So this is a pretty, it's kind of hidden over here, but this is a pretty powerful drop down. You can also filter to people who are diagnosed or self-reported having this eye disease or poverty, things like that. And then the app will automatically filter to those people.
That sounds great. Well, I know it's coming up the 4 o'clock hour here. Any last words, John and David, on this?
So Mitch has a question about the future of funding for our work. We're hopeful that CDC can figure something out. So I think uh internally within the scientific staff at CDC, there's a lot of support for the work we do. CDC is undergoing an interesting time right now. So, and I think they have challenges getting money out the door to anyone. So we will wait and see. And if not, it's been a great run, and we will look for other avenues to continue our work.
Awesome. Well, I'm glad you guys are still sticking with this, and I encourage all those people on the call to make use of it and publish papers on it because I'll get visibility out, and maybe at Arvo too, there'll be some posters on this work. That's a way to kind of get the message out and see how we can, highlight what we're doing. This is one of the recommendations from the NASEM report is to create this vision health surveillance system and encourage surveillance. And this is a beautiful example of how that came about. So I applaud you, David and John, for doing this, and I hope you guys will be supported to continue, and we'll do all our part here to kind of encourage that. And thank you once again for presenting. Next month, we hope to have Dean himself participate and talk about surveillance data that he's done with the Vision Health Initiative, with hopefully possible guests that know more about the Vision Health Initiative and its history to come and talk to us before our meeting at Arvo, where we discuss the NASEM report and talking about how do we come together and get a solid consensus on one voice for vision, kind of moving forward to promote what we're doing in vision and eye care in the United States. So thanks again, listening on a Friday, and thank you again, David and John, for participating. Have a great weekend now.
Yeah,
Thanks
thanks
for
for
having
having
us. Bye, guys.